Marshall. I am the People Services Leader at Goodwill Columbus and a member of the Connect Us Steering Committee. And I'm very much looking forward to Amy's presentation today because as we look at digital inclusion and as we've talked about all morning, we want to make sure that we are forging ahead with digital equity. And there's so much that we can learn, there's so much more data available to us than ever before that can help to inform those practices. So I'm really excited to have that presentation today. Let's see, so this session is critical because healthcare is being transformed by digital innovation. I suspect everyone has had some experience with accessing medical information or getting appointments or test results through digital forms, and that really changes the way we interact with and think about healthcare. So as we move forward in that way, we want to make sure that everyone is able to access those same resources and tools, information, etc. So we want to make sure that it's working for the people who need it the most. Our speaker, Amy Sheon, is the president and CEO of Public Health Innovators and a national thought leader in digital health equity. Amy has pioneered digital health navigator models, used data to make inequities visible, and worked with health systems and tech companies to embed equity into digital health solutions. She'll share practical insights on making digital health meaningful, usable, and equitable, especially for communities historically left behind. Please join me in welcoming Amy Sheon.
Thank you so much, and good morning, everyone. I think I had a chance to meet most, if not all of you, and get a little sense of what drew you here to a session on health. I'm really delighted to be here and have the opportunity to talk with you about how we can apply digital inclusion strategies in healthcare. And for those of you working in digital inclusion, approaching healthcare is kind of daunting. And so I want to help you kind of navigate that a little bit. To add just a little color to the kind of introduction from Jennifer, my whole career has focused on working with vulnerable populations, but also with the side on interest in technology and wanting to make sure that technology reduced disparities rather than exacerbated them. And then the pandemic happened, and then everybody else realized, the problem of technology. Well, for 10 years, I was directing the Urban Health Initiative in Cleveland at Case Western Reserve School of Medicine, and I was very focused on the patient portals starting in about 2013 because I saw them as a transformative opportunity for public health, but healthcare didn't know what to do with it, public health didn't know it existed, and the companies that developed it did it kind of as a sideline and really didn't care about them. Shortly into, and so I began training community health workers at the local community college to be what we now call digital navigators. We didn't even have that word back then. Well, a few months into the pandemic, the first call I got was the Cleveland Clinic saying, we know you've tried to get our attention for years about how to engage our patients with the portal. Can you help us reach them with telehealth because they've disappeared and we know our patients don't know how to do this. Can you help us? Well, 3 or 4 more phone calls like that, and I decided I would never have a better opportunity than I have now to make an impact on what I'm so passionate about. So I took the leap and I quit my job, and I have since been working full-time with digital inclusion organizations, healthcare systems, technology companies, nonprofits, philanthropy, government, on making this bridge between digital inclusion and healthcare. A month before the pandemic, the National Digital Inclusion Alliance, NDIA, invited me to be their first senior fellow to further develop the model I was working on digital navigation in healthcare. A month later, the pandemic came, and I had based my model on work that was already going on in digital inclusion in Cleveland, and that work became the model for what NDIA developed as what we all now know as digital navigators who help 23 million people sign up for the internet with the Affordable Connectivity Program. So I'm really honored to have kind of had a seat at that table as it was going on and to have the opportunity to really advance the work. So what I plan to talk about today are three key objectives. First, to describe the digital health transformation that the pandemic really accelerated, to recognize how digital inclusion is a super social determinant of health, to identify the structural and systemic barriers to digital health adoption that were covered so beautifully by Mr. Pinder, but also talk about strategies for overcoming them in the health context. I then went around and talked to all of you and to find out what your interests were, and I heard a lot about seniors and housing and home health and caregiving, how to stay in your own home, how to combat loneliness, training allied health professionals. So I'll try to work some of that in. And if there's anything else that it doesn't seem like I'm covering, but you really want it covered, loneliness, I heard that, chime in now or whenever. I'm going to try to keep this pretty informal. I have a ton of slides to cover, and I'll go through them really fast, but I don't have to go through all of them. And so if there are things, you want me to pause on, if you want me to skip ahead, give me a signal like that or something. Okay, so it should not be a surprise to anyone that telehealth, which had been around for decades, really, obviously took off during the pandemic. And once healthcare reopened for face-to-face care, the number of telehealth visits dropped, but still continue at a level, much higher than they had been. Now, we know that about 40% of those calls were audio-only calls, and that doesn't get a lot of recognition. And interestingly, the proportion of calls that are audio-only is actually going up. And the reason for that, I believe, is that the people who are digitally, not able to do a video call are the same people who have barriers to in-person visits, like transportation, like inflexible work schedules, like physical disabilities that make it hard to go into the office. So, to me, that's not surprising, that it really points out the work we still need to do. Now, from the very beginning, it was recognized that there were disparities in who was using audio-only telehealth, and that's people who were Hispanic, who were Black, and who are Asian. And a lot of other data have come out that go beyond that I'll talk about in a minute. Now, patient portals, on the other hand, also predated the pandemic, and use of them was growing very, very slowly until the pandemic. And in contrast to telehealth, use of portals has continued to climb dramatically since the pandemic. So now we have about 65% of people who use the portals. Now, the number of functions available in the portals continues to grow dramatically. How many of you use a portal pretty regularly? How many of you use 4 or 5 or 6 or 7, 8 different portals because yourself, your people you care for, etc.? They're all different. You've seen one portal, you've seen one portal. Portal people say. But the other thing is that increasingly, healthcare is expecting you to use the portal. So now you have to check in for your visit. You have to pay your copay. That was a shock the first time I saw that I couldn't get beyond until I paid my copay. And update your medications, answer questionnaires. Anyone else, any other favorite things that they're making you do in the portal before you can see your doctor?
Revisit. It has all the releases that you have to sign.
And all that.
Yeah.
some of the crazy rules around minors. Like my minor children had to give their authorization for me to access their portal.
And
Because
the day
it's Ohio.
your kid turns 18.
Yeah, it's done. Yeah, it just
You
changed.
can't
It just turned,
access it,
it just
yeah.
turned 18.
Yeah.
Is that a FERPA constraint? I mean, it sounds weird, but I think maybe it is.
I think it is,
Yeah.
yeah, but it's, I mean, when he was 13, they're like, well, your
Oh,
mom-
when he was 13.
When he was 13, yeah, the 18 piece, like, yeah, the 13
Yeah.
piece, literally in the doctor's office, they said, do you want your mom to have access to your records, yes or no?
Yeah.
Yeah.
So
That's crazy.
anyway, you know, these are really significant issues that we need to talk about. Now, literature on disparities in equity-based disparities in portal use have been published since at least 2005. So for 20 years, we have known about these disparities. So it shouldn't have been a surprise that early in the pandemic, a discovery was made that, you know, there were big technology-based barriers to telehealth, including broadband and access and digital skills. Those were recognized right off the bat. But again, that shouldn't have been a surprise. In 2017, work that was done in 2015 or 16, done in Cleveland, where I was living, was among the first to discover that patients of a public hospital who lived in neighborhoods that didn't have broadband were much less likely to use the portal, again, back in 2015, 2016, and that they had huge disparities in who was using the portal. So it wasn't at all surprising what we then saw, these disparities replicated in telehealth, years and years later. But if you take away one thing from today, I want it to be that telehealth and even portals are just the beginning. And everything, when I read digital equity literature and all those state digital equity plans and what are your goals around health, help people use telehealth, right? That's the obvious thing that people think about. But when you think of it, telehealth can't be used for a certain number of health situations. And it's probably something you're only going to do, once or twice a year, maybe once a month. But a portal, say, is something that you can use continuously. You can have many more interactions with your healthcare system. But portals and other technologies have continuous monitoring. Some of them have continuous monitoring, and that's incredibly powerful. So an app that you have on your phone might be measuring your gait and may detect a possibility that you have Parkinson's or that your Parkinson's is getting worse. They may detect that you're at a risk for falls. It may monitor, with your permission, there may be an app that you've downloaded that monitors your speech and your intonation and can indicate whether you have a recurrence of depression. It can indicate whether you're going into areas that are triggers for relapsing substance abuse, things like that, right? So the ways that these technologies can help people with health goes far beyond even your interactions with healthcare. So, that's really a key finding. Now, to illustrate this with a story, my partner has prediabetes, and knowing about these continuous glucose monitors, he asked his doctor to prescribe him one, and he convinced his doctor to prescribe him one, and it was covered by his insurance. Well, he called me after 3 very frustrating hours of not being able to get the monitor that he had stuck into his arm to sync with an app on his phone. I'm like, well, have you read the instructions? Well, there aren't any. Well, we go online and we find the instructions, and then we find for a list of compatible devices, go to this other website that's not hot linked and you have to type it in. And then you get out a magnifying glass to read the very small print of the devices that are compatible with it. And his device, which was a newish but low-end Android phone, was not on it. However, An iPhone 7 at the time was on it, and somebody in my family had discarded an iPhone years ago, and he was like, well, I'll give it a try. Well, he had never used an iPhone before. It took me 3 hours to get the phone just to turn on and update everything, the software and everything, because it hadn't been turned on for years. And then I had to convince him, he's a retired IT professional. Did I mention that? His last job in IT was customer support in the finance industry. It took me hours to convince him that it was okay to get an Apple ID and that the data being collected and that he was putting into the app about everything he ate and his physical activity would not bleed over into everything on his other cell phone with all of his other accounts. Well, his reaction, when he found out it wouldn't even run on his phone, was to be pissed off at his doctor. Why did my doctor prescribe me something without checking to know that I'd be able to use it? And why is it that insurance is willing to pay a no doubt hefty monthly fee for this device to be sent to him, for the monitoring of it every day and blah, blah, but not be willing to pay for a device to make a phone to make sure he could use it? What doctor has time to go through all this? None. They don't. And they wouldn't know how to do it, if they had the time to do it. So there's such a role for digital inclusion, but people who do digital inclusion and digital navigation, they need to be trained on applying those skills in the healthcare context. Oh, sorry, I didn't show you that. That was the teeny tiny list of devices that are compatible. Well, during this time, I heard an advertisement for a consumer glucose monitor that did not require a prescription. So I walked to and I'm such a techie, of course I wanted to be the first one on my block to get this. I paid $99 to get 2 devices that each lasted for 2 weeks to track my own glucose. And what I found was that you could see after every meal my glucose went out of range, and it took just days for me to figure out how to make, and I had a pretty healthy diet, but to make small changes to keep my glucose in range. My partner, who had been spent 2 years trying to make sure he didn't progress and need insulin, didn't get worse but didn't make any progress. It took him a couple of months, but he learned to make very small changes to what he ate, the combination of foods he ate, and most importantly, to do even 5 minutes of walking after meals, and it kept his glucose in range. So that really shows you the power of seeing the feedback, the real-time, immediate feedback, day in and day out, the power of that. Encouragement from his doctor, meeting with the dietitian, going to peer support groups, me modeling healthy behavior, me nagging. Zero, well, I don't know, it might have been worse, but let's just say we didn't make any forward progress. A couple weeks on this, and the healthcare system probably saved itself tens of thousands of dollars in healthcare expenses for someone with diabetes. Okay, so now I'm going to shift to the concept of digital inclusion as a super social determinant of health. Who has heard that phrase before?
The super social phrase?
First of all, who knows social determinants of health? Is that familiar? But digital inclusion as a super social determinant of health. So let's break that down. SDOH, social determinants of health, are the conditions in which we eat, grow, pray, work, play that affect our health every day. There are conditions in our neighborhood, and that translate into our education, our income, and things that affect our health very dramatically. So those are the social determinants of health. Digital inclusion, I imagine you're aware, it used to be you would just ask, do you use the internet, right? It's a binary. It has no longer been binary for many years, and there was recognition, particularly by NDA and in the Digital Equity Act of 2021, that all 5 components of digital inclusion were needed for people to be able to really harness the power of the internet for any purpose. So that meant not just being connected by using the library's Wi-Fi, with all due respect to the libraries for providing Wi-Fi, but having home internet is not the same. Borrowing your ex-daughter-in-law's broken smartphone with a cracked screen, yeah, you could check yes, I'm on the internet, but you are not meaningfully on unless you have a personally owned device that meets your needs. And for most of us, it's probably multiple devices that are optimized for different circumstances. Making a presentation, checking my email on the plane. Having access to skill training, having applications that are accessible and meet your needs. And this one really gets lost, having tech support separate from training. Tech support is when you need help in the moment. Help, I've got a telehealth appointment and I can't get the call to go through. So digital inclusion is necessary to address all of the social needs that come out of adverse social determinants of health. Get an education, sign up, try to apply to a school, try to get a student loan, try to apply for a job, my goodness. Right, all of these things, digital inclusion is required for all of them. And so for that reason, in 2021, I co-authored a paper called Digital Inclusion as a Social Determinant of Health, and we quoted the person who really is the one who called it the super social determinant of health. 2 of these co-authors are from Columbus, Cindy Seif, and Angela Seifer, who was one of our kickoffs this morning. I am humble bragging to tell you that even though we weren't the first person to say these things, this paper seems to have become the go-to reference. It has been cited more than 450 times in countries all over the world from every area of healthcare, and even recently for the application in outer space. So, we've gone beyond the planet. So I'm really proud that, we put that out there and that healthcare does seem to be really embracing, not just because of us, but, all these citations are clearly an indication of growing awareness in healthcare about this. Now, a couple of years ago, I was asked by Health Affairs, which is a very prestigious health policy journal, to write a policy brief for legislators that explains what are the pathways from digital inclusion to health equity. And so we said, well, there are 2 main pathways. One is digital inclusion can help you get access to health care, and if it mostly helps people who have the worst access to health care, then it will improve health equity. And we said it can help people address the health affecting social factors like education and income. But we knew intuitively that just giving somebody all of digital inclusion is not going to translate into better health that one can see on a population level. And why is that? Well, and as the speaker this morning said, but I don't think he showed you the maps that really make the case very compellingly. We have huge disparities in health outcomes that follow a very recognizable geographic pattern. And in these communities that are most darkly colored, rates of high blood pressure are about 4 times the rates in other areas. And for diabetes, the disparities are even more significant. It's about 8 times. And we know that these are conditions that are linked to these social factors. And of course, guess what? Not a surprise that these are the same areas where people say they have no internet access. But as I mentioned, it's no longer good enough to look at binary. These are national data, and they show you for different population groups the proportions that have that do not use the internet in gray, and you can see that it's people with no college education, income under $30,000, and people who are 65 and older are the least likely. But that's really not the whole picture on the disparities. When you look at who only has mobile access as the only way of getting on the internet, then you really see that the Black and Hispanic populations that had caught up in terms of do you use the internet, they still have this big disparity in being smartphone dependent, and huge gap by income, and huge gap by education that persists. I'll wait till you snap that, thank you, because I worked really hard to get all those little numbers. It tells a story. But here's the kicker, and you know this, but seeing it in maps to me says it a lot better, and that is the areas where we have concentrations of poverty, of race. This particular map is of the proportion of residents who are Black, and the one that doesn't get so much attention is segregation by education. And the reason that that's really important is that the education level in a neighborhood was one of the biggest factors predicting whether an ISP brought internet to a neighborhood. And so what we find on a population basis is that people who don't have any college education, it took 20 years for them to even have as much internet use as people who had some college education. And you don't get good at using the internet overnight. And so when you see these statistics, yes, I use the internet. Well, how long have you been using it for? That would tell you something. But it also means that, not only these populations lost a head start, but the neighborhoods lost a start. And when you figure that these are neighborhoods where you already have poor education systems and lack of job opportunity, add to it, and we're not going to give you the internet for 20 years, what does that do? The damage that does to community is tremendous, and you really don't hear that perspective. And I'm talking about health. Why am I talking about this? Other people should be talking about this, but another thing is a discovery a couple years ago, a study of 800,000 offers that were made to households in 38 cities for internet. And what they discovered was offers that went to neighborhoods that were the least white and the most poor were most likely to be the slowest offers that internet service provider gave, and at the highest cost. And so on a per megabit basis, poor people in poor and segregated neighborhoods were paying up to 100 times per megabit for the speed of internet that they were getting. Now, that was actually not illegal, except for the brief shining moment under the prior administration when the regulations for the Digital Discrimination Act were passed and went into effect. It only would have been illegal if an ISP went into a neighborhood and went household by household and said, okay, the people in this household have low income, so we're gonna give them a bad offer, and the wealthier people next door, we're gonna give them a better offer. That would be illegal. But to pick the neighborhoods by what is the overall education, race, income, that wasn't illegal. And it was briefly, but again, we've gone back to, I think that was rescinded on day one of the current administration, so it is now legal to discriminate on a neighborhood basis. Now, there's still another smoking gun. Does anyone know that I haven't put out there yet? Any idea what that's going to be? Any guesses? How many of you know what this map is or have seen it before? Economic redlining, back after the Depression, when the government collaborated with the banking industry to send assessors into every neighborhood and look at the quality of the housing stock and their rating of the quality of the people who lived in those neighborhoods using the most heinous language you could imagine. Columbus's data don't show the language that the assessors wrote up of neighborhoods, but many other cities do, and they say things like, this is a neighborhood with a heavy infiltration or a growing prevalence of Negroes. I mean, they just put it out there. This is a neighborhood of people who don't care about their houses. This is a neighborhood of, laborers who don't have a lot of money. So what did they do? They literally colored neighborhoods in red on maps and said, do not lend to those neighborhoods. Neighborhoods in yellow, lending wasn't advised, but it wasn't prohibited. Neighborhoods in green and blue, yes, these are great. One thing that made them great was that they had restrictions against renting houses to Jews, to blacks. I don't know if immigrants, people from certain countries were ever part of covenants, but there were other ways of making that happen. Now, we know that housing discrimination became illegal in 1968, but the damage, not only wasn't undone, but it didn't stop. This is a map today of the social vulnerability of neighborhoods, and red means a neighborhood has high social vulnerability, and that's an index of all these different metrics that are put together. And one thing that I really noticed about this, I mean, not only the obvious of how similar it is, but also how during historic redlining, you had some mixing of yellow together with green and yellow together with red. And when you look today, that's gone. And so what you may find is if you're in a distressed neighborhood, that's all you see for miles around you, and you can't cross the street and go to a nice grocery store. And if you're in, the green area, poverty and segregation don't exist because, everything's good where I live. And it should be no surprise then that we have a 27-year difference in life expectancy in Franklin County. Not today, but these data were from like a decade ago maybe, that very much tracks historic and contemporary social vulnerability. So with that, we knew that there was more we had to do to that model because we knew that just giving people digital inclusion, it might allow one person to get an education, but could they really use that education to improve their health, circumstances? The answer was no, and so what we added, and it literally took me a year to figure this out, we added the notion that the neighborhood's socio-demographic characteristics interact with digital inclusion because those characteristics determine whether the internet went in, when it went in, what the price and quality were, and they also affected what is going to be the impact of digital inclusion work. Are you, if you're able to apply for an education program, are you going to be able to translate that into ways that improve your health? And, I had to kind of write apologetically at the end of that article, I hate to tell you, but if you think that digital inclusion is going to improve people's health, I wouldn't be betting my mortgage on that, at least not in your lifetime. And so it's important to be very realistic and honest about, what can be done. Well, Health Affairs came back and said, now we want you to write a follow-up brief that focuses just on the direct connections of digital inclusion to health. That paper is coming out next month. It's on there, it's only on the internet, and it's in front of the paywall or behind the paywall, whatever it is, so you can get it for free. And we talk about how portals and telehealth can improve health equity by, as I mentioned, like making it easier for people to access care. But we have this whole other direct pathway that bypasses healthcare and says, if digital inclusion can empower people to use technology to improve their own health, that can really have a huge impact on health equity. Unfortunately, the sad history in healthcare is that healthcare had to invent a law for a phenomenon that happened so frequently that they needed a law, and it's called the inverse care law, and that means that actions taken by healthcare that build on inequitable systems are going to make health worse or make health equity worse. So, that's really where we are, right? You don't have an iPhone, sorry, you're not going to be able to fix your glucose, and, do not collect go. Perhaps we should make a Monopoly game, go straight to insulin and diabetes and amputation of your legs and blindness and, all the other things that come with it. Okay, so with that cheery note, we're going to switch gears into what on earth can you do about it. And I'm going to talk about 5 different sort of categories of things that I think are ways to think about strategies for working with healthcare. The first is leadership and, what is a healthcare organization's goals? They have goals and ambitions. And in 2008, they actually published, healthcare leaders nationally got together and they published the healthcare triple aim. Here are the 3 things that healthcare is trying to accomplish. We want better health for populations, we want to deliver care better, and we want to do it at a lower cost. Well, that was all well and good. And along about 2014, they added, we got to take care of our providers because they're being burned out. Why are they being burned out? I'm sorry, because I was encouraging patients to use the portal and send messages to their providers. And by 2014, providers were already getting slammed with messages because the health systems hadn't put in workflows for how to triage the messages so that the doctor wasn't the one answering the question of what time is my appointment, right? And so that provider well-being, really, certainly portal messages weren't the only thing, but they invented the term called pajama time, which is about physicians answering portal messages after they put their kids to bed. And in 2022, in the wake of the George Floyd killing and Black Lives Matter, healthcare actually added health equity as an objective. And it has actually been transformational. I have seen changes in healthcare that I wouldn't have thought possible. And it's now at this really weird limbo state because we know that equity is now such a dirty word that I changed what I call myself. Instead of digital equity and inclusion consultant, I'm a digital engagement and innovation consultant. So I kept the DEI, but you get it. Anyway, so it's unclear really, how healthcare is going to respond to all these great things that they've adopted for health equity. But when you think about these aims, it's not hard to think about articulating how can digital inclusion help healthcare achieve its aims. Now, what I've found when I've been approached by digital inclusion organizations wanting to engage with healthcare, their question is often, we want you to help us get healthcare to pay for X, devices, our programs, blah, blah. And I'm like, stop right there. Healthcare is not going to do that. But what healthcare might do is work with you to help them achieve their goals in ways that also serve your needs. Now, so these are the national goals, but local healthcare institutions, of course, have their own goals. And they articulate these by doing community health needs assessments and doing a strategic planning process that looks remarkably like what was done to put together the digital equity plans and the BEAD plans. The same process, the surveys, the stakeholder engagement, the priority setting. But it is very rare to find any of these health plans that talk about digital inclusion. Now, true story, I Googled Franklin County Health, Community Health Plan, and I go to the table of contents, and there's an entry in the health plan for digital inclusion. I'm like, holy cow, I've never seen that before. I hit pay dirt, and I make up all these slides, and I start going through it, and I'm like, why are they showing maps of Massachusetts? Franklin County, Massachusetts. That's one of their key health objectives. But what they do is, locally, they've articulated 4 key priorities: addressing patients' basic needs that affect their health, like education, housing, and the like, behavioral health, maternal and infant health, and racial equity. Well, it's not hard to see some overlap between the priorities in your digital equity plans. And the Franklin County Digital Equity Plan identifies a number of priority population groups that turn out to be very similar to the priority groups that healthcare uses. Now, I'm kind of going to shift into the next strategy I want to talk about, which is data and analytics. How many of you have heard the phrase, Uber isn't a transportation company, it's a data company? Mm-hmm. How many of you have heard that? Okay, I recently went to an event where a hospital in Suma County, Ohio, is being converted to a digital health care system. No hospital, no physical institution, but everything is being done digitally and remote. Or there is still a hospital, but the staff will largely be people who are in a remote center, and there's a robot that's in the patient's room listening and blah, blah, blah. Healthcare collects enormous troves of data thanks to the billions of dollars they got after the 2007 financial crisis to adopt electronic healthcare records. They also track automatically a whole bunch of things, like every click you make in the portal, whether you succeeded or failed at your telehealth visit and wound up having to go to audio, whether you've called tech support and what you've called about, that's all captured automatically. And so what that means is healthcare can just go into data that it has, and for hundreds of thousands of people at a time, they could characterize the digital readiness of all of their patients. As people have published the algorithms for how to do this. Work done at OSU, they are among the pioneers in how to mine electronic health patient portal data to classify patients according to what is the digital skill complexity of the different things that patients are doing in the portal as a way to classify patients' digital skills. And that's really helpful on a population basis, that you can look at the skill level of population groups by geography and different populations, and that can give you insights into structural barriers that are facing populations. It can also show you if you're doing interventions, let's say your local library is having a big MyChart class, right? The health system could compare MyChart adoption rates in the area right around the library with similar areas that aren't right around the library and see, did that make a difference, right? So you can do things that you don't have to do a survey of a small number of people that's going to have a lot of, inaccuracy to it, and get data on, millions of people at one fell swoop. Now, another institution, Johns Hopkins, they automated predicting the risk that somebody who had an individual who had a scheduled telehealth visit was going to fail. And they preemptively started calling those patients to offer them assistance. Let's help you practice. Do you have X, Y, and Z? Right? And so that's something that every health system could do, but having insights from people who know digital inclusion can be very helpful. Now, digital navigators are, of course, an invaluable solution that helped 23 million people get affordable connectivity plan programs, and then many of them lost their jobs because that money ran out and many of the households got disconnected. These people would make wonderful navigators in healthcare, but I've been hired by a number of communities to train digital navigators to work in healthcare, because it turns out there's a number of questions and concerns and things that they really need to learn to translate those skills to healthcare. But I think it's really worth doing. So now let's think about a health system that wants to scale up rather than just inferring someone's digital readiness from their data, actually screening. Well, how many of you have been asked by your provider, do you have enough food to last, do you have enough money to buy food for the whole month? Is your housing secure? Health systems have by and large universally adopted social needs screening, sometimes called SDOH screening, social drivers of health screening, and they have a workflow and a workforce to do it. So you would think it's not a huge lift to add some questions on digital readiness. But it is something of a lift, and I've seen health systems do it so badly that, surprise, they only find 2% of their very low income population that doesn't use the internet. Well, maybe it's because you did your screening by sending out messages over my chart, and you wonder why you're not finding people not connected. So it can be done badly, but it can be done well. Now, there are two ways that health systems can do this to simplify it. One is they can do it in-house, or they can farm it out to community organizations that have digital navigators. And so, they could do the assessment in-house, but then if there's a gap, refer the person to a community organization to get a device, do the things that community digital inclusion organizations are good at and that healthcare is not good at. And then once the people have those basic skills, then somebody at the healthcare system can be trained in digital health navigation and teach the patient to use a digital health tool. But what healthcare needs to realize is that teaching someone to use a digital health product is not like teaching someone to use a spacer with their asthma inhaler. It's all about digital skills. And so sometimes it might be better to take a digital navigator and teach them to teach health, either in the community. How many public libraries are doing MyChart training? A lot of them, I'll tell you, because I've heard from all of them. But those community organizations need healthcare to partner with them to develop those trainings. Now, I think community health workers are the ideal workforce to do this, and this brings us to another big healthcare strategy, which is workforce development. In 2019, I published this with one of the community health workers I trained that showed how the community health worker duties map onto what a digital navigator does. Now, there are some published and free digital health navigator trainings. This is probably the most widely known in healthcare, but it assumes that you're training a clinical person, and it really ignores all the basics of digital inclusion, but it will help a digital health navigator be able to assess apps and decide what is a good and credible health app. and how do you interpret the data in a health app? Now, you don't want someone who's not a healthcare professional doing that, but there's some merit to this model. The National Telehealth Resource Centers, or this is the Northwest Regional Telehealth Resource Center, has 2 curricula for digital navigator training on telehealth and portals. So I can definitely recommend those. Now, another strategy on the workforce side is that, how many of you are familiar with the phrase community anchored institution? So digital inclusion, indeed looks at community anchored institutions are ones that can offer the internet and, reach people for various things. And digital inclusion considers healthcare a community anchored institution. Well, healthcare has its own meaning of anchor institution, and there is in fact a national network of healthcare anchor institutions. OSU is one of 75 nationally that are part of this. But what healthcare means by that is they want to leverage their huge physical footprint and economic footprint and just kind of authority in a community to improve the neighborhoods they're situated in. And they do this through their hiring practices, through their purchasing power. We're going to get our laundry done by local, laundries in the neighborhood. We're going to invest in our physical communities. We're going to do advocacy, et cetera. Well, these healthcare anchors say almost nothing about digital inclusion. And I'm sitting here looking at this and saying, but it could help you do the things you're trying to do. So I think this is a big opportunity for approaching healthcare and saying, hey, you have these ambitions. Let's talk about hiring digital navigators. Let's talk about paying for digital navigators to get certified as community health workers, because guess what? That might mean that healthcare insurance will pay for their work doing digital navigation. And that is the brass ring. When people are thinking, oh, I'm gonna go to healthcare because that's where the money is, healthcare ain't where the money is. The insurance companies that pay for healthcare is where the money is. And this notion of getting someone qualified to be somebody that insurance will reimburse for their services, that's the prize. And getting digital navigation, screening somebody, getting them a device, teaching basic skills, and then teaching digital health skills, that's where the money is. And so, this anchor institution framework is one way that you can try to leverage it. Now, partnerships is another thing that healthcare systems do. And there's a notion in health and public health, my public health colleague here, that you only institute screening if you have a plan for doing something about the problem that you find. And so the old way of doing this was every social worker or whatever in a health system would have their own little spreadsheet where they would cross things out and update it of where they were going to refer people in the community. Well, when this universal social needs screening started coming, they needed to be able to scale this up. And so these closed-loop technology referral platforms have arisen. And Unite Us, it's called Unite Ohio, is used in a lot of Ohio health systems. But so they have listings of where do you refer people for housing, for utilities. But what they don't have generally, except in some parts of Ohio, because I worked with them in Cleveland, they don't necessarily have listings of the digital inclusion organizations, and they don't necessarily have the detailed screening tools that could find out this is somebody who would like a Spanish-speaking, an organization that's for, immigrants from Spanish-speaking countries, helping them with their patient portals, right? So you need to get that specificity, and the digital inclusion community and digital navigators could really help do this. NDIA has a map of their affiliates around the country. There were about 200 of them when I went to the first NDIA summit 10 years ago, and there are now 2,500 of them. And these are some of the Columbus area digital inclusion organizations that are listed. But it is by no means all of them. Unless every one of you sees your organization listed, it's not going to come up. Now, I had talked about reimbursement opportunities. This was a President's Commission on Cancer Navigation Through Technology that I spoke at. They put out a report just at the end of the Biden administration with all these strategies for getting reimbursement for using technology to navigate in healthcare. As I mentioned, the status of those is uncertain. But the new administration does have some things that they're doing that create opportunities for embedding digital inclusion. One is they're developing the digital health ecosystem and interoperability framework. And the administration is publishing requests for information to get people to tell them, how do you think we should structure that ecosystem, the health technology ecosystem? Thanks for asking. I submitted a reply with about 8 pages of things that they could do that related to digital inclusion. Well, I encourage you to look at all the things that they're looking for information on. This is just a small number of things where they want advice on. But you can also go back and look at what are the things other people suggested. Now, I asked AI to look at all of the 980 comments that were submitted about health technology and tell me how did my contributions stack up? What surfaced from what I wrote? And what they said was, and I know they flattered you, so it told me what I wanted to hear, but it said that the comments submitted by Public Health Innovators were really unique. They were among the only ones focused on equity. They were novel in focusing on digital inclusion. They went across all of the different priorities. And the comments offered concrete policy options. So I tell you this to say, your comments, can make a difference. I don't know if anyone other than AI, recognized these comments, but it is an opportunity. Finally, another thing healthcare can do, like with their purchasing power, is insist that technology that they purchase meet your patient needs. Language translation, MyChart, Chinese for California, for example. And for people involved in development of technology, get people who've been digitally excluded and have them be partners in development of technology. The regulators, the FDA who approves technology, get them to say, we're only going to authorize your app if it will run on low-end and old smartphones, right? Or else build into the price providing the patient with a phone, making sure insurers will pay for that phone to go with the glucose monitor. This is a toolkit that NDIA supported me to give them advice on how to embed digital inclusion in the development and deployment of technology in healthcare. So there's a wealth of resources here that I encourage. Franklin County had a great exemplar with the Digital Equity Coalition pilots, where they gave out iPads to seniors. They had medical students deployed as digital navigators. And the Veterans Administration has long been a leader in this. They started giving out technology, but they realized they needed a white glove service to help people get the technology up and running. They needed to provide 2 years of support to go with it. So they've really been a wonderful exemplar about how to embed digital inclusion in healthcare. So now we're going to get to brass tacks, and that is, what are you going to walk out of here and do as a result of something you've learned today? And before I get to that, I will just give you this as a little cheat sheet. And this is, here's a list of all the different roles in healthcare that might have something to do with digital inclusion. These might be the kind of people you want to connect with. Now, unfortunately, they're very siloed, and sometimes their goals are in opposition. So the person who's responsible for patient experience in healthcare, wanting to get those patient ratings high, they want patients using portal and messaging their doctors. The person at the health system who's responsible for recruiting providers and keeping them happy does not want patients slamming them with portal messages. So you, as the digital inclusion person, could work with them to find the middle ground to say, hey, let's help you figure out how to triage those messages, and let's help you figure out how to help patients know how to send you messages that fit into the kind of ways you want to help them. Templates. How about that? Drop downs, pick things, instead of having the patients, write out what it is they want. Okay, so I'm going to stop here. I probably should have done that a long time ago. And just open it up, either questions or tell me one thing you might walk out of here you could see yourself doing to engage with healthcare, leverage healthcare around digital inclusion. I know this is not a quiet group.
My organization does a lot of work with seniors, and our CEO specifically is a physician by trade. I think one of the things I want to start gauging our seniors a little bit more on, and that's something I really never thought about, was are they actually using MyChart? How are they interacting with that? Do we need to teach them some strategies on how to use MyChart a little bit more effectively on top of some of the other programming that we're doing? So I think first thing that comes to mind is MyChart, and can they even navigate through that portal first of all?
I'm going to give you a secret, and so I'm only telling you no. In 2013, I approached Epic, the company that makes MyChart, and says, I would like to do MyChart training with our local library, but I need like a sandbox where I can let people get a fake ID, an ID, and be able to experiment around, or at least get copies of the screenshots that I could use to build training. Do you know what they said to me? They said, if you use any of our images, even screenshots of your own MyChart account, we will go after you on copyright, privacy violations. It's contrary to the agreement you signed, blah, blah, blah. 2013. 2025, they're doing it.
Yeah.
So if you pay for, like, if I have a platform, it's in a lot of money. In thousands, tens of thousands of dollars just for me to set them up.
So you're saying you have that?
I don't, because of how expensive it is, but yeah, just to go to them and like have administration.
So now they have, basically a template of PowerPoints that show all the different functions. Another client of mine built an interactive simulation of MyChart, but they did that without MyChart.
Yeah.
But about 2 weeks ago, we had a call that brought them together with Epic, and Epic was very excited to hear about that platform. And so it could be that they'll make that available to all of you. And the idea would be substitute in the images from your MyChart at a particular health system, so that it's really personalized. Who else? Yeah, seniors was definitely something that came up, and I should have mentioned home health aides and caregivers, that they need digital inclusion services so that they can be the proxies.
So we work for National Church Residences and so affordable housing for seniors as well. And I almost see this as twofold: track for seniors themselves or the end user, but also the track for the professional, like you're saying. Speaking of Epic, again, many of our systems follow the program, not the senior. So your access to, you need 15 different access portals, because it might be Epic, but then it might be point-click care, then it might be our own platform. So the professionals also need some kind of, and we're not good at that. But the senior side, we're, have a lot of legislation, advocacy, and support for HUD to even consider digital skills navigation as being a reimbursable activity. They don't recognize that. And they don't recognize affordable housing being able to offset some costs for units to have access to internet. There has been some talk about it being moving away from internet being a luxury to a necessity. So just like your heat and your electric and all that. So we're not there yet, but that is a struggle that we continue to see. So we can teach it, but if they don't have internet in their building, it's another hole. So it's almost like we have to resolve that. So we're pounding the pavement for those initiatives, and we are starting to see some pilots where low and, our RAD for PRAC types of renovations to some of our HUD buildings are allowing us to put that in there as part of the cost offset. But that's
And healthcare organizations, they can carry a heavy weight in policy and advocacy. So think about engaging them as your partners to make the case, because for a healthcare system to say, having our patients be connected electronically will save everybody money.
Well, one area that, I don't want to Wendy's horn, but I will. Wendy is leading some of our digital skills navigation programming, and some of our affordable housing properties are always, the operators are always like, oh, just get the job done. Like, yeah, we have so many other things to worry about. But finding that nugget that interests them, such as paying their rent online. If you can get a senior to pay their rent online through like Rent Cafe, which is a portal, now we have their attention. Now we have their interest to go, oh, maybe there's something to this. And so we're starting to peel back those layers too of, if we demonstrate the pre-survey, the post-survey, the confidence, now we're starting to see rent is paid on time. Now we have more interest to prove that, take the data somewhere else and then get the interest. So we've incorporated that. We're starting to see that.
Great example.
And I will say, I think, the same way he had asked, we are doing, at least us, and I think Chase uses probably the same model, is that we are doing some of the MyChart in our digital classes. It's not nearly enough, I'll be honest with you. It's enough to like get their feet wet, but there could be classes among classes just on that. And we're discovering, a class I did yesterday, we really honed in on that because that's what the students were asking for. But I definitely think it could take its own lane and be just for that alone. But so we are touching upon it, but not nearly as effectively as we could be.
I mean, especially with the state of Ohio being recognized as one of the states that are going to start piloting Medicare, Medicaid, artificial intelligence coming up in January. I think it's going to be really critical for our, for that, specific demographic to, one, be confident in using the internet, and two, being able to navigate through whatever is going to happen with this, pilot program. Which I don't know, is making me a little nervous in some instances, but at the same time, again, we think about, what does that digital inclusion look like, right? If everything's being done with artificial intelligence and that specific demographic doesn't have access to the right internet or right device to even support the right healthcare, for that individual. So I think those are questions that are, swirling around my mind right now.
Yeah.
My question is, when you're talking about the internet and the portal, and you're talking about the seniors, especially with the national residency, what about those seniors that not only don't have access to the internet, what about those seniors like my mom who don't even know anything about the internet? Mm-hmm. So about paying the rent on time or even having any type of access to anything, you say computer, you say internet, they look at you like you half crazy.
Yep.
And then you have our generation that's trying to teach them, but they're so set in their ways that they just don't have the know-how. I mean, what do you do when you run into a situation like that, especially when you have seniors that are quote-unquote independent, and you're trying to welcome them to this new world, and you got AI going. I mean, what do you do? Like, where did you find a solution?
I will tell you that, almost all of my clients have been nonprofit, But every once in a while, when I find a for-profit company that I really believe in, I will take them on as a client. And one that I have recently joined up with is a company that has a tablet that is made for seniors. And it is so simple that, you know, the person can push one button and have it call their child. The adult child can call the tablet and have it just accept the call, and you can look in on mom, you know, and call out to her, right? And it also is connected with healthcare, and it has skill building built into it. And I found that it's really approachable for people who are starting at zero. So there are solutions.
What's the
out
name of
there.
that?
What's the name? Claris Companion, CLARIS. Tell them I sent you.
There's actually a lot of those devices. If you go to a conference, you're filled with all these like technology options, but none of them are paid by plans, Medicaid or Medicare. So you almost have to have, but to like your mom's point, it's a great gift to give your mom, but these all usually have some kind of a subscription. I don't know if this one does, but there's great devices on the market, but they're not cost effective for a senior anyway, who's on a limited income, to be able to take advantage of some of those things.
This one does operate through intermediaries that get reimbursed. So for example, a health plan that say is going to be able to get reimbursed by having the senior put in their vitals every day.
Yeah.
So they do that, the health system gets reimbursed for it, and it's enough money that they can afford to pay for the device. It's a good model, that's why that was kind of what I needed to see to know that this has potential. But I'm sure there are others out there. Yeah.
So do you have any information about the different types of telehealth and what people are more willing to use, or like mental health services versus?
Oh, I'm so glad you asked that. The strongest evidence comes from the VA, the Veterans Administration, because they have one electronic health system across the country, and they've been doing this a long time. They have very strong evidence for substance abuse and mental health, especially PTSD, that it increased, people's ability to continue their care during and after the pandemic, reduce suicidality, reduce, substance abuse relapse and the like. So those are definitely two big areas for telehealth. I think we're over. I will stay around for a moment, but in fact, they're going to call on us to talk about what we got out of this, so I don't want us to be like.
Thank you.
Thank you.